Welcome to the number 7 online presentation of the ICD family of lens designs. The ICD lens has a design to cover all of your patient's needs. The ICD 16.5 is aimed towards diseased eyes. The ICD 14.5 is for lower asymmetry and more regular corneas, and the ICD 16.5 toric is suitable for toric scleras and those with a toric overrefraction. When deciding whether to use the 16.5 or the 14.5 ICD lens, there are numerous factors to consider. The ICD 16.5 is designed for irregular shaped eyes and those with a visible iris diameter of greater than 11 mm. The ICD 14.5 is aimed towards more normal shaped and regular corneas, those with smaller irises of less than 11 mm, and those for whom insertion and removal with larger lenses is difficult due to small eyes or a strong blink reflex. Choose your initial ICD diagnostic lens based on the corneal condition you are fitting, or use a topographer to calculate the sag and simulate the fit first. These charts are provided in the fitting sets for both the ICD 16.5 and the ICD 14.5 lenses. For example, if you're fitting somebody with keratoconus with a corneal diameter of greater than 11 mm, start with the 4500 micron sag lens. Or, if you have a small cornea and you're fitting the 14.5mm lens, and you have a normal depth eye, start with the 3400 sag lens. The ICD lens has three main zones. The CCZ, or the central clearance zone, is the central part of the lens. The LCZ, or limbal clearance zone, is the mid-peripheral area over the limbus. And the scleral landing zone, or SLZ, is the part of the lens which lands on the sclera. All can be adjusted to fit your eye accordingly. These lenses are assessed using fluorescein evaluation, so lenses should be inserted filled with saline with a drop of fluorescein so you can assess the fit with a blue light and Ratten filter. The optimum fit will show good apical clearance and clearance in fact over the entire cornea including the limbus, as shown in the upper right photo. If the fit is flat, you may see apical corneal touch or bearing, or simply a too thin a layer of fluorescein over the entire lens. Both of these will require a steeper sagittal depth. The lens clearance can be assessed in two ways, using either a slit lamp with a thin optical beam or an OCT. Using a slit lamp, compare the known thickness of the contact lens of around 350 microns to your tear layer. You're aiming for around a 1:1 ratio, or equal tear thickness and lens thickness, and this way you can ensure you have around 300 microns of clearance. Using an OCT you can do this more accurately, although it's not essential. There have been numerous studies conducted to work out how much settling is possible with miniscleral lenses. Pacific University conducted two studies in 2012, both over 8 hours of settling. The first one gave around 96 microns of settling into the conjunctiva and the second one 127 microns. John Mountford also conducted a study in 2012 over 30 days and found around 146 microns of settling. And this is why we suggest 300 microns on initial insertion of the first lens to allow cushion for such settling. Once you have the appropriate central clearance, have a look at the limbal clearance zone, or the area of clearance over the limbal part of the lens. The image shown shows minimal limbal clearance and would need to be adjusted. You can assess limbal clearance using both a slit lamp or an OCT. With a slit lamp, we recommend using a white light to assess how much fluorescein bleed there is over the limbal zone and onto the sclera. You can also use an OCT, which will help you see exactly how much clearance you have over the whole limbal zone. If you do have inadequate limbal clearance, you can increase this area by increasing the LCZ or limbal clearance zone area in steps of +5. Each positive change or increase in the sag is recorded as a plus measurement. If you need to decrease this zone, it would be a minus measurement. The next step is to assess the scleral landing zone, or SLZ. The lens should land smoothly on the conjunctiva, creating no pinching or blanching of blood vessels. If there is inappropriate scleral landing zone, you will see conjunctival impingement, and this will look something like the image on the left if it's quite severe. You can see redness in the blood vessels and bunching of the conjunctiva. You can also assess this very well with an OCT, and it will show the edge of the lens digging into the conjunctiva. If you see this, decrease the scleral landing zone by -1 steps or more if necessary. Any changes you make to the limbal clearance zone or scleral landing zone will change the overall sag of the lens, and this should be borne in mind when fitting these lenses. Each step change will create 25 microns of change in the sag. If you increase the limbal clearance zone by 5 steps, this will increase the overall sag of the lens by 125 microns. If you flatten the scleral landing zone by decreasing it by -1, this will decrease the overall sag of the lens by 25 microns. There is a fourth zone in the lens, known as the PCCZ, or the peripheral corneal clearance zone, that can be adjusted by number 7 consultants in order to account for these sag changes. This concludes the introductory presentation on the ICD family of lenses. If you'd like more information on the ICD toric design, please see the ICD toric presentation. For more information, please visit www.icdlens.com, which has more information, technical specifications, and a great presentation hosted by Randy Kojima, one of the lens designers. Thanks for listening.